Well, hi, Chad Higgy here. I'm one of the flight paramedics at STARS and also a clinical educator there. And, over the last several months, myself, Shell Ryan, Paul Turini, and Gavin Greenfield, who's on the phone, have been working on updating these protocols. The protocols have been improved specifically around the protocol that we're going to talk about today, which is the restrictive protocol. This is what we think is going to be applying to these patients with COVID-19. So it's has a lot of troubleshooting, compliance, and also treating refractory hypoxemia. So on the phone, I have Gavin Greenfield. So Gavin, thanks for being here.
Yeah, thanks. It's Gavin Greenfield. I'm one of the transport physicians out of the Calgary base and the medical director of education for STARS. And that was a good intro, Chad. Yeah, thank you.
These protocols and the purpose of our screencast today is to update our AMC on the changes to the protocol, and specifically, we're going to walk through each one of them. So we're targeting our AMC. At STARS, we use the Hamilton T1, but I think this education, or the principles that we're going to talk about in the protocols, they could apply to a lot of different providers, whether you're in an emergency department, whether you're a fixed wing provider, or you're doing transfers in between hospitals. So anyways, there's a big audience. So if you're not one of our AMC, I think this is still potentially applicable.
And to that point, this education will be posted at stars.ca/COVID-19 clinical, which anyone can access.
Okay, awesome. Let's get into it. So, like I said, we're going to target. We're talking about the ventilation protocol, the restrictive ventilation protocol. So I'm just navigating through the AHS EMS protocols, and you can Google these. If you Googled AHS EMS protocols or CCMCPs, you'd find this. And obviously there's an application that we've talked about before as well that you can download. So I said normal restrictive, and here it is. So I have the protocol up here now, Gavin, and I just wanted to walk through it with all the people that are tuning into this. So,
yeah, and just to be clear, Chad, it's called the normal lung and restrictive lung, and we did mention this when we went through our universal protocol, but if you're ventilating someone with normal lungs, it's the same protocol. It's just you're never going to get over to the right. And we're going to spend a lot of our time on this algorithm on the right, which talks about refractory hypoxemia and plateau pressure. And again, if you're ventilating someone with normal lungs, you're going to quickly just kind of go down the left and everything should be fine.
Right. Yeah. Good point. Good point. And I guess the reason that these are classified together is that the strategies essentially are the same as far as minute ventilation targets. But obviously, if you're really sick, then where there's going to be some things we're going to be troubleshooting, like low SATs or high airway pressures. And so the protocol can help. Is you're right, is targeted at both those people. So to start off, in this protocol, if you follow the cursor, normal. Just everything is just thought to be normal minute ventilation, normal volume. So the mode, whether it's a volume or pressure controlled mode, I don't think it really matters. At STARS we use the Hamilton T1. It's a pressure controlled ventilator. The mode that we pick is PRVC. So we've labeled this that Hamilton actually refers to as CMV plus. That's the normal mode, and we refer to that as PRVC. That's a common phrase that people in the ICU or in the emergency department understand. Where some of the names, like on the Hamilton T1, says CMV plus, which is proprietary. We like PRVC because it's not proprietary. Gavin, what else do you have to say about that?
Yeah, and PRVC stands for pressure regulated volume controlled. This does cause a little bit of confusion amongst users of the T1 because we put in the volume. We enter, and you'll see when Chad gets to the tidal volume below, that is our target, and that's what we enter. I think a descriptive term for our Hamilton T1 is a volume targeted pressure controlled. It truly is a pressure controlled ventilator, but it does target a specific volume.
Exactly, and it picks the appropriate pressure in order to achieve that volume, and that's where I think that people get confused. That it's a volume controlled ventilator, or is it a pressure controlled ventilator? It is a pressure controlled device, and we'll talk about that later when we talk about the inspiratory flow waveforms that relate to pressure control. But anyways, picking a rate, moving down. So rate, normal rate, 16 breaths per minute, 8 cc's per kilogram of ideal body weight. On the Hamilton, it's got a real nice feature that if you after you've measured someone's length, then you can just program that into the ventilator, pick male, female, and it'll calculate. For ours, we've defaulted it so that it does the math for us, and we come up with 8 mils per kilo without having to do too much math other than enter the patient's length. Inside of all the CCMCPs is an ideal body weight table. So if you don't have that luxury, then you can just refer to the table. So we start everybody off with an FiO2 of 1. If your stats say high, we decrease the FiO2. We'll discuss that later in the algorithm. But if your stats are persistently low, then you increase the PEEP, which is the next button that we have defaulted to 5 centimeters of water. And the IE ratio we set it to 1 to 2 or less. And some of you may recall that in previous versions of this protocol, it said 1 to 2 or greater, and we realized later that actually 1 to 2 or greater would mean a ratio less than 1 to 2, which would be 1 to 1, and that's certainly not what we meant. What we meant was a ratio, IE ratio of 1 to 2 or 1 to 3 or 1 to 4, something like that. So that actually technically is less, but we had that in there for a long time the wrong way. So just moving down the algorithm, again, Gavin, you talked about earlier that if you're just a patient that's been intubated due to an overdose or what have you, then I don't imagine you're going to have problems with oxygenation. You shouldn't have problems with high airway pressures. You're just going to follow this down. No, and probably be decreasing the FiO2 and starting to move. But if you happen to intubate or come across one of these patients that are intubated that have serious lung pathology, then maybe the SATs are low, and so that's this first diamond says, are the SATs less than 94%? And if they are, feel free to increase the PEEP up to 10 centimeters of water, and then it says for us to consult a transport physician to go over some strategies that could be used on someone that doesn't initially respond to 10 centimeters of PEEP. So, Gavin, can you walk us through this list?
Yeah, absolutely. So just to recap, if your increase in PEEP accomplishes SATs of greater than 94, you're quickly back to the left side of the algorithm. If not, we've got this list. The purpose of having this list here is so the AMC and the transport physician can work from the same list and decide what may or may not be appropriate in this particular patient that we have in front of us. So in the initial settings, we've got an FiO2 of 1, so we'll just that's in this list. We're going to stay there if we're hypoxemic. Optimizing chest wall compliance. So compliance refers to how much volume change you get for a given pressure. And what we'd like to do is be able to deliver as much pressure effectively as we can. And so if we can decompress the stomach, that we include the diaphragm in chest wall compliance. If we can decompress the stomach, there will be less resistance to diaphragmatic expansion, and that will improve chest wall compliance. Chest restraints are often an issue in our environment, and loosening them can improve chest wall compliance. If you have a burn patient, an escharotomy can help. And sitting patient up is an easy thing to do, especially our larger patients. They have a lot of soft tissue to move with every breath. And if we can sit them up, we offload the lungs, we offload the soft tissue from the chest wall, and we should improve compliance.
That should have been the first thing on the list.
As we're going through this separate, exactly. We can probably reorder that. That's a pretty easy switch. Sedation and paralysis. So here we have a patient where oxygen is in limited supply. We have a hypoxemic patient. So if we can decrease the other side of the equation, the oxygen demand side of the equation, we can improve things. And so by taking away the work of breathing with the mechanical ventilation along with sedation and paralysis, we can accomplish that. So that's something to strongly consider in any patient that has any degree of hypoxemia. Positioning. So ideally we'd like to match perfusion with well-ventilated lungs. So if you have a process that is somewhat unilateral, so you have more opacification on one side, put the lung with more aeration, the better looking lung, dependent. The gravity dependent perfusion, they'll get more perfusion to that lung, which is being better aerated and better ventilated. So you should have an improvement in your SATs. And again, sitting patient up is here as well. Higher levels of PEEP. So above 10 centimeters, we encourage a conversation with the transport physician. And some of your patients with ARDS, which is what this patient population with COVID-19 generally present with, do require higher levels of PEEP. So that is, if your hemodynamics allow, that is certainly an option. Optimize oxygen delivery. So we can have all the SATs we want. We can have SATs of 100%. But if we have no cardiac output to push that oxygen, which is bound to hemoglobin, to push that out to our tissues, we're going to have tissue hypoxia. So here's the difference between hypoxemia and hypoxia. We have SATs of 100%, but because we have no cardiac output, our tissues are starving for oxygen and hypoxic. So we're going to optimize oxygen delivery through appropriate volume resuscitation, vasopressors, inotropes, etc. The next one, permissive hypoxemia. So this refers to a concept. Let me just lay this out. Let's say we have SATs of 88%. So we have hypoxemia, we have SATs of 88%, but our plateau pressure, and we're going to talk about plateau pressure shortly here, our plateau pressures to accomplish those SATs of 88% are 30, 31, 32, 33 centimeters of water, getting into the range where we're getting uncomfortable from a lung injury point of view. Well, let's say that same patient with SATs of 88% is doing really well. Stable hemodynamics, a normal lactate, no evidence of end organ perfusion. Before you intubate them, their brain was working normally. They were conversing with you, just dyspnea. Well, maybe that's a patient that we consider that 88% is okay because there's no evidence of tissue hypoxia, and to accomplish 94% in this patient, I'm probably going to need to get my plateau pressure at 35, 38, I don't know, something higher where we're getting more uncomfortable about potential lung injury from higher pressures. So that's the concept of permissive hypoxemia. A recruitment maneuver. So this is most easily done on the Hamilton T1 by pushing the inspiratory hold key, which is on the right side of the front of the ventilator. When you push this, the ventilator will maintain the peak pressure until you let it go or until 15 seconds. It automatically allows exhalation at 15 seconds. But in that entire 15 seconds, it will maintain flow such that the peak pressure is maintained. So this is something to consider. You do need to be aware that if you've got a patient with significant resistance, and we're going to go through the difference between resistance and compliance shortly here, but if you've got a patient with significant resistance, their plateau pressure will be lower than their peak pressure. And so you may increase your alarm limit such that your peak pressure might be 50 or something like that, with your plateau being normal. When you do that inspiratory hold, it will go to that peak pressure. And over 15 seconds, it will equilibrate and you will get a plateau pressure of 50 centimeters of water. So just be cognizant of that if you have raised your peak pressure alarm limitation. Increasing eye time is almost like a recruitment maneuver on a breath-by-breath basis. We're essentially putting the alveoli under positive pressure for longer time. And of course, the other side of this is a decreasing E time, excuse me, and then that can result in issues with the patient being able to fully exhale. So you need to monitor your waveforms to make sure the patient is still fully exhaling and is not developing any auto PEEP if you're increasing your eye time. And of course, if you increase your eye time enough, you will get to actual inverse ratio ventilation where your eye time is actually longer than your E time. And then the final point is consider accepting higher plateau airway pressures. So let's lay out another example for this. So that same patient that we described earlier, but now the SATs are 76% and their lactate is 9 and they're really sick, but they've got a decent blood pressure. Well, maybe, again, once we've tried to optimize our chest wall compliance and do everything we can there so that we don't have to have these really high airway pressures, but if we've done all that and we're still at a plateau pressure of 30, 31, 32, 33, and our SATs are 76%, and we've got decent blood pressure, you know, this is a case-by-case difficult decision, but maybe we actually accept higher plateau airway pressures in the short term to try to improve that severe hypoxemia, ultimately, even more importantly, trying to improve tissue hypoxia. So, yeah, that's a summary of that list, and I think we'll go back to you, Chad.
Gavin, one more question for you, though. What do you think about a proning patients? You know, this document came out. Some crews feel uncomfortable about it. What's your thoughts?
Yeah, great. Thanks for raising that. So under positioning, proning is an option that can help improve hypoxemia. A document has been produced and put out there, and you'll see it at stars.ca/COVID-19 clinical. And I know this raises anxiety in crews. I think this document was absolutely necessary. Dr. Mike Betzner, our base medical director here in Calgary, was the author of this document. And essentially, it's a framework for the rare event when everyone's on board. So the sending site, the receiving intensivist, the TP, the AMC, when everyone's on board that this is the right thing to do, and it's very specific circumstances. It's well laid out in that document. But this document provides a framework for how we can actually do it as safely as possible. So by producing this document, we are not saying that every one of these patients is going to be transported prone. And ideally, none of these patients are transported prone. But this is the patient population where it may come up. And again, just important that we have a framework from which to work.
Perfect. Yeah. So after we've addressed the I think that was a great summary of all the stuff from a refractory hypoxemia perspective. That's an important list to sort of have in your head, and I think it's a good reference as well. So if the patient has high airway pressures, so the next question is, if their peak pressure is greater than 30 centimeters of water, if their plateau pressure is greater than 30 centimeters of water, what do we do? So this is where I'm gonna navigate to another screen here. So this is the alarms, troubleshooting, and modes screen. So if you went back to the main screen, these are some options. And so I just wanted to contrast these two inspiratory flow waveform patterns. So there's two images here. So like we talked about earlier, the Hamilton T1 is a pressure-controlled ventilator. And so in this first image here, this is an image, this is on the y-axis is flow in liters per minute, on x-axis is time. And so we can see the inspiratory flow on this initial image gets to 0 inside the inspiratory time. This is where exhalation begins. So this entire section right here is the inspiratory time. Flow gets to 0 inside the inspiratory time. That means that there's been equilibration between the pressure sensor and the lungs, and right down to the alveolar units. I know, Gavin, you like that. So Gavin, please jump in and help me out here, because this is an important concept for everybody to understand. This is something we've taught our crews a couple of times in the mechanical ventilation course. But the reason this information is so important is it helps you make good decisions as to what to do next when you come across a high peak inspiratory pressure alarm in a pressure-controlled ventilation setting.
Yeah, perfect. So, I mean, I think you said it really well, Chad. I'll just emphasize it because it's an important waveform. And so, yes, in image 1, the flow has gotten to 0 within the I time. So imagine that now all this oxygen and air that has been put in has time to equilibrate all the way down to the alveoli. So therefore, the pressure that the vent is showing is the plateau pressure. And what we really care about is the pressure in the alveoli. That's where lung injury takes place. And in this image 1, the peak equals the plateau.
So you can imagine if you come across this peak inspiratory pressure limitation, peak is equal to plateau. So your troubleshooting can really be focused on compliance, the things that decrease chest wall compliance. And so that list is down here. So decrease compliance of the lung. Here's some causes of it, and some things that you can do to improve compliance. This list essentially was in the refractory hypoxemia list as well, something to think about early on. So maybe you've already done that. But if you haven't, that's something you want to just make sure you do. And if you can, then you're going to decrease the targeted volume if the patient will tolerate it. I know in that list of refractory hypoxemia, tolerating higher airway pressures is one of the considerations, but this is probably a conversation you're going to have with your transport physician.
Yeah, so just to be clear, Chad, you do all these troubleshooting to improve your compliance such that you hopefully get more volume with your given amount of pressure. But if none of those things work and you're still not attaining your targeted volume, your next step would be to maybe decrease your targeted volume depending on what their SATs are. And yeah, well said.
The second image is different than the first. In the second image, again, flow and time, and in the second image you'll notice that flow actually stays high throughout the inspiratory cycle. Flow does not drop to 0 inside the inspiratory time, and so there's not that same equilibration happening that we talked about in the lungs, and as a result, peak pressure is higher than the plateau pressure. Gavin, is there anything, can you add clarity to that in any way?
Yeah, well, I don't know. The way I look at it is that, yeah, so we've got, this will be a case where we've got some kind of resistance, and Chad will go through the list, but there's some resistance between the corrugated tubing and the alveoli somewhere. And so the machine's pumping in a bunch of flow, and then boom, the I time ends. So let's, in this case, it looks like it's set for about 1 second.
Yeah.
So the I time ends and it cycles to exhalation while there's still flow happening. So there has been no time for equilibration. All that flow has not gotten down to the alveoli. And in that waveform, when that scenario is happening, the peak pressure will be higher than the plateau. And put another way, the plateau pressure, the pressure at the alveoli will be less than the peak pressure that the machine is displaying.
That's why in this case, if you come across that peak inspiratory pressure limitation, then like we said, there's a resistance issue. You can troubleshoot that by focusing your attention on the things that potentially contribute to it. So, suctioning the endotracheal tube, making sure the tube holder's not on too tight. It's all listed here. Things to potentially consider that would contribute to that. If those things don't fix the problem, then and this is a patient, or this is a person that that we could consider increasing the pressure limitation, or at least trying to figure out where the plateau pressure is sitting.
Yeah, totally agree. So we try to fix this resistance. If we still have the same wave pattern, again, we just said the plateau is going to be less than the peak. We don't care about the peak. The airways experience the peak pressure, and they're rigid, they're solid. We won't injure them. We care about the plateau. So yeah, I think you have two choices here. You could increase your peak, and we've kind of arbitrarily said maybe at a maximum of 10 centimeters. So increase your alarm by 10 centimeters of water, and then measure a plateau. Or if you're uncomfortable doing that, just measure a plateau right now. You'll get an idea of how much less the plateau is than the peak, and you can use that number to guide how much you're going to increase the peak pressure alarm limitation.
Yeah, and on some ventilators, you can just hold that breath in. So at the end of inspiration, you can hold the breath in, and that's called an inspiratory hold. The machine will then measure the plateau pressure. On the Hamilton T1, we use the equation of motion. And this is an equation that we've tested a whole bunch of times in the lab, and it really does seem to work well. And so that's the expired volume. It's not the targeted volume. It's actually the volume that comes out of the patient over the static compliance plus the PEEP. And so that's something that I think is quite useful. We have a calculator that we have in house that we can just plug these numbers into, which is really nice. If you're not a STARS person, then I think there's other calculators out there. And again, the math isn't that hard if you just had a calculator. But just something to note though is it's the PEEP, it's the total PEEP. So it's the amount of PEEP that you have dialed in plus any auto PEEP is the exact formula.
Yeah, and just to emphasize what Chad said, so many ventilators, what they do is they block exhalation. So they allow time for that flow to settle out, and then that will give you a plateau. We already discussed what the Hamilton, when we push that inspiratory hold button, we already discussed what that does. It actually maintains flow to maintain your peak pressure. So it does not measure a plateau pressure when you push that inspiratory hold key.
Okay, perfect. Well, I think we can move on to the rest of the algorithm, but just before we do that, because I have the screen up, I'll just point out this patient with the inspiratory resistance. There's a lot of expiratory resistance, and I'm not sure if there's auto PEEP or not. You'd want to go in and take a look in this case, but it might not be a lot of auto PEEP, but there might be some there, and so that's just something that's the expiratory flow waveform, and that's another important waveform to take notice of. So moving back though, so if we've talked about what to do if the peak pressure is greater than 30, and then now if the plateau pressure is greater than 30, optimizing compliance and potentially decreasing the targeted volume if the patient's able to tolerate it from a SATS perspective, and then obviously we move down to get a blood gas, and if the pH is less than 7.1, we say consider increasing the respiratory rate. Gavin, this conversation about acidosis, this is one that keeps coming up, and it's a concern that a lot of crews have, is that when this pHs start getting down to 7.1, what do I do?
Yeah, I mean, we all have that concern. We don't like acidemia. maybe the number by itself isn't as dangerous as we once thought, especially when it's a respiratory acidosis. But let's talk about this. So I think in this scenario, if the pH is less than 7.1 and your E time, your exhalation flow is getting to 0 within the E time, meaning there is no auto PEEP, there is no breath stacking, then you may very well want to increase the rate. The danger with increasing the rate is your E time will be shortened, of course, if you don't change the I time as well, and that can lead to the potential for breath stacking. So if you don't have evidence of that, I think it's a very reasonable thing to increase the rate to try to gain some respiratory compensation to improve that pH.
Okay, well said. And then, be obviously mindful that the faster that rate, and if patients have poor hemodynamics, that's something that can play a factor as well, I guess.
Yes, in general, the faster the rate, the higher the intrathoracic pressure will be, and we know that can have negative hemodynamic effects. So always a balance.
Finally, in this COVID population, I doubt we're going to be in this situation where we have the luxury of decreasing the FiO2 if the SATs are above 97%. But if there's still a possibility of that. Hyperoxia is thought to be a bad thing. Do you have anything to add in regards to hyperoxia, Gavin?
No, I think it's well accepted now that it is harmful to patients, and you'll see that 94 to 97% range in throughout many of the CCMCPs, the protocols.
Awesome. So the next, and then the program leads you down to transport with pre-notification, and these COVID situations. I think that that's going to be really important, and I think that there's been protocols laid out for that. Gavin, anything else that you want to add about the protocol in general?
No, I don't think so. I know you're going to ask for some feedback here shortly, but I think that's everything. And but we certainly encourage questions and feedback.
And I just want to point one last thing is just that the notes, some of the things that we've been chatting about. There's some brief notes here that you can refer to that will go over some of the same things that we were just chatting about. So that's all we have for you. There's going to be other screencasts that cover the other protocols, and we'll work through those over the next days and weeks. And like Gavin, you just said, we'll put an email up here if you have any comments on either the protocol or the type of education that we're doing here. So thanks very much, everybody.
Thanks, everybody.